Everyone, it's 8 o'clock, and I think we'll get going with the Journal Club. So this morning we have two presentations as usual, but the second presentation will not be a journal article presentation, but a discussion about the clerkship program at Toronto and modifications that are pending. And through Yoga Parent will be leading that discussion. People who have an interest in education are welcome to stay on for that part, but I understand that some of you may not be staying on for the second half of the Journal Club. So the first presentation is by Katie Krause. Her slides should be visible to you, and I'll turn it over to Katie.
Okay, so everyone can hear me?
Yes.
Perfect. Okay. My name is Katie. I'm a P2I5 in Geriatrics. I'm just doing a short journal presentation today. And the journal that I chose to present was entitled Estimation of Lifetime Risk of Alzheimer's Disease Dementia Using Biomarkers for Preclinical Disease. I have no disclosures. So just generally, biomarkers to date have had limited clinical use. They're difficult to obtain. We need PETs or CSF fluid. There's limited influence on management to some extent, and some people may never experience clinical disease if they do have biomarkers. To date, there's no lifetime risk estimates for AD dementia that have been reported which account for biomarkers for preclinical conditions, but there have been some lifetime risks based on longitudinal follow-up cohorts, such as the Framingham study. They postulate that lifetime risk estimates might help clinicians, patients, as well as families gauge likelihood that a preclinical condition will manifest into clinical symptoms in a patient's lifetime. So my article attempts to estimate lifetime and 10-year risk of Alzheimer's disease dementia based on age, gender, and biomarker tests for preclinical disease. The authors used a multi-state model for progression of Alzheimer's dementia through preclinical and clinical disease states to estimate lifetime risk of AD dementia. The model is based on the National Institute of Aging Alzheimer's Association framework for preclinical stages of AD. This framework postulates that the AD pathology typically begins with a state of asymptomatic amyloidosis, that is amyloid beta deposition, that can be detected by PET imaging or low amyloid beta 42 CSF. The disease process advances to neurodegeneration, which can be detected using biomarkers, including elevated tau in CSF, neuronal dysfunction based on FDG PET scans, or hippocampal atrophy cortical thinning via volumetric MRI. Subsequently, clinical signs and symptoms emerge, including subtle cognitive decline, onset of MCI, possibly due to AD, and then ultimately Alzheimer's disease dementia. The model they used is shown here, postulates that there is a sequential progression through the normal asymptomatic neurodegenerative and symptomatic states, and they stop the model at the symptomatic state. There is evidence also supporting alternative pathways, so they have outlined these with the blue arrows, and they also allow and recognize that there is controversy there. Just very quickly, the multi-state model used is a discrete time Markov model, which is useful when a decision problem involves risk that is continuous over time. It assumes that a patient is always in one of a finite number of discrete health states or Markov states. What they kind of assume is that a future state depends only on the current state, not events that occurred before it. So the model is evaluated through matrix algebra as a cohort simulation or as a Monte Carlo simulation, and it allows for more accurate representation of a clinical setting. The authors use different rates to help with this model. So the transition rate they use are based on two large published epidemiological cohort studies that measured biomarkers for amyloidosis and neurodegeneration. They also used the 2014 death rates by age and gender for persons in preclinical states 1 through 4 and assumed this remained constant through the future. And then they used they multiplied these rates by the hazard ratios in Mayo Clinic study to estimate death rates for states 5 and 6. From this model, they produced two separate estimations. The lifetime risk is the probability of developing AD dementia during one's lifetime, and they calculated the 10-year absolute risk, which is the probability of developing AD dementia over a 10-year span. They also undertook some sensitivity analysis, and comparisons were made to other longitudinal studies, which I'll touch on in a moment. So table 1 shows the lifetime risk of AD dementia for females by preclinical or clinical disease state and age based on the multi-state model. And table 2, apologies for the teeny tiny font here, but table 2 is also 10-year risk for AD dementia in the same population. What I'll highlight is that in both tables, the overall trend is that risk, whether it be lifetime or 10-year development of AD dementia, increases with increasing disease states. Obviously, so for example, a 6-year-old with a normal state or state 1 has a 20% lifetime risk of developing AD dementia, whereas a 6-year-old who has amyloid and neurodegeneration, such as state 4, has a 41.9% lifetime risk of developing AD dementia. In table 1, lifetime risk seems also to decrease as population ages. The theory behind this, the authors state, is that the expected remaining lifetime in which AD dementia can progress is less with advanced age. The 10-year risks are also useful when identifying which persons are most likely to progress in a shorter time period, which might be more clinically useful and useful for planning to use this research, this information in a research setting. This is table 3 and 4, and they show lifetime and 10-year risk for AD dementia in males by preclinical and clinical disease state and age. The same trends still hold true here, 4% risk by disease state, but overall lifetime risk of males is less than lifetime risk of females, mainly due to mortality rates being higher amongst males. Table 5 compares their lifetime risk estimates of AD dementia by age and gender, but not biomarker preclinical state, with those of several other studies. Just to review this table, the Framingham estimates are lower estimates than from our multi-state model, especially for males. And the author assumed that these lower risks were possibly due to higher death rates at the time of the Framingham study, which occurred in 1985, versus the 2014 death rates that they used for this study. However, on the opposite end, the rates of AD dementia are higher in both the Rotterdam and Adams study. And these two studies, so the Rotterdam, the data was collected in 1990 to 93 and published in 98, and Adams was collected in 2001 to 2009 and published 2017. So arguably both of these studies, or all of these studies, occurred prior to the 2014 death rates that they used. So if we were using the theory that the authors postulate of higher death rates, they should all be lower. So this may be an oversimplification of why the numbers are different, or it might be a false kind of assumption. So I don't think there is a perfect tool to assess this article, but there are some user guides around important questions to ask when trying to critically look at this type of literature. I chose to use a guide that was published in JAMA in 2017 by Anna Alba, and colleagues at UHN, so she's a cardiologist at UHN. And it presented 4 questions. That guide, which is a guide to assessing the risk prediction or diagnostic capabilities of a prediction model. So for question 1, where they asked, do authors provide information about both discrimination and calibration of the model? I say kind of. It's quite difficult to interpret given its the complexity of the supplemental material. I did struggle with this because there's some complicated mathematics that they use, but this model does discriminate those with high and low risk, but it doesn't give a C statistic, which would be important when you're assessing a binary outcome in a formed prediction model, which isn't really what the article is doing, so it's difficult to apply this exactly, but I did think they did offer enough information, as well as with calibration. I do believe they did offer enough information there. With question 2, what is the discriminatory ability of the model? Does the model adequately discriminate between patients of varying risk? Again, just to give a little more information about what discrimination is, it refers to how well the model differentiates those of high risk of having an event from those of low risk, so in our case, progression to AD dementia. It depends on the distribution of patient characteristics in the population in which the model is being used. So in our case, age, sex, and biomarker status. And I do think there is good discrimination. However, again, it's not a true model predicting a binary outcome with no C statistic. So I said yes, but not a true model. Question 3, how well calibrated is the model? Does a visual representation suggest a consistent good fit between predicted and observed outcomes in patients at different risk categories? Again, for a little bit of clarification, calibration informs us about how similar a predicted risk is to the observed risk in a group of patients. So in our case, when these outcomes were compared to longitudinal observational trials, the numbers were either higher or lower than these studies. The numbers varied anywhere from 5 to 10%. So it might not make a terrible difference in clinical decision making. For example, if you have a 21% versus 35% risk of development of AD, but this could cause some changes to how you treat someone clinically. So overestimation might cause more investigations, more aggressive intervention, or patient fear about progression, versus underestimation causing the opposite, lack of investigation, less aggressive intervention, or patient indifference. It's also difficult because unlike most of medicine where you can say a disease is present or absent, those diagnosed with AD dementia in the longitudinal observational trials might have had a different pathology or confounding diagnosis. So the observed might not be exact or true. And then finally, question 4, when comparing two models or a modification of an existing model, does one of the models predict risk more accurately? And unfortunately, because there is no other model like this one, which includes biomarkers, I'm unable to answer this question, so I wasn't able to apply it here. So what's the clinical significance? So the results demonstrate that most persons with preclinical disease will not develop dementia during their lifetime. This is important clinically because it could help us decide when biomarker testing may be appropriate versus when it may not. For example, does an 85-year-old with no cognitive impairment need biomarker testing? We all say no, but this could help support this judgment by saying, your risk is in a study has been 18.9% if you did have neurodegeneration as well as amyloid, which is fairly low. It could also help the conversation in those who have already had biomarker testing and allay some of the fears of that positive biomarker test if they have a low lifetime or 10-year risk. A key limitation and source of uncertainty is around the transition rates between disease states. These rates were based on some of the largest longitudinal studies available to date, but carry their own important potential sources of bias. For example, the Mayo Clinic study of aging was not a diverse population, so these estimates may not hold true in a diverse population. They also assume death rates are constant since 2014, which is not, it's just an assumption, it doesn't hold true, and these rates will change with lower death rates. And finally, cognitive impairment can be multifactorial. So those with biomarkers may have developed cognitive impairment from other things such as vascular disease. So we cannot know for sure if clinical symptoms are alone from progression of an AD dementia. So there's my whirlwind short presentation. If you have any questions, thanks.